similarly, just like any other major subject, has about 14 questions out of 200 in the MRCP Part 1 exam. And we had discussed that broadly rheumatological disorders can be classified as metabolic bone diseases, arthritis, vasculitis, connective tissue diseases, and regional pain syndrome. In the previous lecture, we discussed about metabolic bone diseases, arthritis, and vasculitis. So today, I'll just recapitulate the vasculitis part, just review them because that's the most important part in the rheumatology, and they'll continue with the connective tissue diseases and some regional rheumatological diseases. Then we'll do questions, the past question, just like what we had discussed in the previous session. So this is just the initial 5-6 slides are on revision of what we have discussed in the previous lecture. So we have discussed about the arthritis. As you know, arthritis can be classified as inflammatory and non-inflammatory. Inflammatory arthritis means the patient has some systemic symptoms like fever, fatigue, weakness, in addition to the joint pain. And when you examine the joints are swollen, it is warm, there's tenderness over the joint, and there could be associated stiffness, which is usually more in the morning and decreases it usually increases with after inactivity. So inflammatory arthritis can be further subdivided based on the etiology as one of the four. Seropositive arthritis, that means patient has positive rheumatoid factor. We have seronegative arthritis, that means patients usually are negative for rheumatoid factor. And but these group of disorder have something in common, that is they usually affect the axial skeleton and usually have asymmetrical involvement of the peripheral joints. That's why they are together, they are considered as seronegative spondyloarthropathy. We have few examples of seronegative spondyloarthropathy, including ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and inflammatory bowel disease associated arthritis. We also discussed few infectious arthritis, including gonococcal infection. We also discussed reactive arthritis. We also discussed reactive arthritis, a part of seronegative arthritis. Under infectious arthritis, basically we are discussing infection which directly can lead to arthritis. So important ones among them for the exam is the gonococcal arthritis and chikungunya. We have crystal-induced arthropathy. Example, we have gout and pseudo-gout. So we have discussed in detail about gout and pseudo-gout in the previous lecture. Now, this is the classification of vasculitis, which we had discussed in the previous session. So vasculitis is basically inflammation of the vessel wall. We can classify them based on the size of the vessel which are involved. So larger vessels such as aorta and their branches are usually involved in what's called large vessel vasculitis. We have two examples, Takayasu arteritis and giant cell arteritis. We have medium vessel vasculitis, where the smaller arteries such as the mesenteric arteries, renal arteries are affected. Examples are polyarteritis nodosa and Kawasaki disease. In this Kawasaki disease, you should see in children, and in the exam, you should know about polyarteritis nodosa. Then coming to the involvement of the smaller arteries, usually these small vessel vasculitis are usually associated with what is called ANCA. ANCA stands for anti-neutrophil cytoplasmic antibody. That's why these we have three important differential or etiology for these. One is microscopic polyangiitis. Second is called as granulomatosis with polyangiitis, previously termed as vaginous granulomatosis. The third one is eosinophilic granulomatosis with polyangiitis. The previous term was Churg-Strauss syndrome. In addition to the ANCA-associated vasculitis, there are some other immune complex vasculitis which can affect the smaller blood vessel, including cryoglobinemic vasculitis, IgA vasculitis, which was previously known as Henoch-Schönlein purpura, again a disease which is predominantly seen in children. We also have anti-GBM disease. Again, it can affect the smaller vessel, usually present with the involvement of the lung and the kidney. So these are the broad classification of vasculitis. So I'll just quickly go through these vasculitis because this is the most important topic in rheumatology. So temporal arteritis, as we discussed, it's a large vessel vasculitis where the patient has some overlap with polymyalgia rheumatica. Patients are usually elderly. They have usually rapid onset of Symptoms, usually headache is the most common presenting symptoms. Apart from headache, they can have jaw claudication, which is the pain while chewing movement. If you when you examine them, if you, when you palpate the superficial temporal artery, you might elicit some tenderness. You might have some scalp sensitivity while brushing the hair. In addition, they may have symptoms such as polymyalgia rheumatica, which is the pain and the stiffness in the proximal limb muscle, usually the hip girdle and the shoulder girdle. Remember, there is no weakness, it's only a stiffness and ache. They may have systemic symptoms, but the most important factor which you should remember is the involvement of the ophthalmic artery. Okay, so because similar to superficial temporal artery, ophthalmic artery may also be involved, resulting in what's called as ischemic optic neuropathy, where the patient can have sudden blindness, and most of the cases this blindness is irreversible. Okay, and when you get to examine the fundus with the ophthalmoscope, you might find some pale swollen disc with a field defect, what's called altitudinal field defect. So, in addition, you examine, do certain investigation, you'll have a very high ESR. If you're going to do a temporal focal in nature, you may not find lesion at the site of biopsy. So, biopsy does not always rule out the disease. So this is the picture which is showing the different manifestation of temporal arteritis. You have systemic disease where the patient has systemic symptoms. In addition, the visual loss is the predominant complication which you are worried about. So if you're suspecting temporal arteritis, you should start them immediately on high dose IV steroid, usually a dose of prednisolone of 1 mg per kg per day, which will decrease the chance of visual loss. And generally, there will be a dramatic response to the treatment. So urgent ophthalmology review is required and visual damage is often irreversible. So if you're doubtful about the diagnosis, you can do a temporal artery biopsy, but do not wait for the confirmation. Always start them in steroid at the earliest, because once the visual loss is set in, it is usually irreversible. Second large vessel vasculitis, which we discussed for Takayasu arteritis, it usually involves the aorta and arch of the aorta and branches of the aorta. It is more common in Asian people compared to the non-Asian descent. The patient usually present with headache, accelerated hypertension, heart failure, claudication. Patient can come with aortic regurgitation. Kidney is less likely to be involved, but rarely you can get some kidney involvement. But kidney is usually involved in small vessel vasculitis. Treatment of Takayasu disease is usually steroids or azathioprine. This is an aortogram which is showing a dilated ascending aorta, and you see a diffuse bulge of the carotid artery, and where you have the involvement dilatation and then narrowing. Again, you can see some stenosis of the left subclavian artery as well. The medium sized vessel vasculitis is polyarteritis nodosa. Again, you are going to get inflammation in the medium sized vessels. So usually the mesenteric artery and the renal artery. Most of the time it is associated with the co-infection with hepatitis B. These patients have very different spectrum of symptoms. So it's very difficult to pinpoint or diagnose this condition, polyarteritis nodosa, because it's a multisystemic disease with quite vague symptoms. The patient may have fever, malaise, arthralgia, hypertension, because probably involvement of the renal arteries. They can also present with involvement of the nerves, what is called as mononeuritis multiplexa, which is a condition where there is involvement of two or more peripheral nerves which are non-contiguous. That means one in the upper limb, for example, ulnar nerve involvement in the upper limb and common peroneal nerve in the lower limb, or other combination could be oculomotor nerve palsy in the head and neck area, and a common peroneal nerve palsy in the lower limb. These are the various combination of mononeuritis multiplexa. The patient can have renal failure, testicular pain because of the involvement of the gonadal arteries. They can get abdominal pain because of the involvement of the mesenteric arteries. Remember, medium vessel vasculitis are negative for ANCA. So generally you do not find ANCA here. They can have pulmonary hemorrhage. They can present with coronary artery involvement with myocardial infarction. So this is a polyarteritis nodosa. Usually involves the heart, the GIT, and they can present with the involvement of the peripheral nerve as well. Now, moving on to the small vessel vasculitis, which is the vaginous granulomatosis, and the most common among the small vessel vasculitis. So, as we discussed in the previous lecture, it usually presents with involvement of the upper respiratory tract, lower respiratory tract, plus renal involvement. So, upper respiratory tract symptom could be epistaxis, sinusitis, nasal crusting. Lower respiratory tract involvement include hemoptysis, and kidney is usually causes crescentic glomerulonephritis. So one of the severe form of kidney involvement is called crescentic glomerulonephritis, where inflammatory cells are going to enter into the Bowman space and going to proliferate within the Bowman space and form the crescent shape under the when you examine under the microscope. Patient may have granulomatous inflammation involving the nasal septum, and there could be saddle nose deformity. The investigation, they are highly positive for C-ANCA. C-ANCA stands for cytoplasmic ANCA. It is positive for protein called proteinase 3, PR3. So PR3 is an antigen which is present inside the neutrophil, which leads to the formation of antibody, which is known as C-ANCA. Chest X-ray may show cavitating lesion. Lung biopsy may show some granuloma with vasculitic changes, or a kidney biopsy may show crescentic glomerulonephritis. Management includes steroid and cyclophosphamide. Do remember that management of the small vessel vasculitis follow the same pattern of steroid and cyclophosphamide. Those patients who have lung involvement with pulmonary hemorrhage may require some plasma exchange. So this is the saddle nose deformity, and this is the patient who has got a cavitating